Your time starts now. You have a 70-year-old gentleman presented initially with visible hematuria, had a flexible stroscopy showing a bladder lesion, subsequently had TURBT. TURBT is reported as G3pT1 TCC of the bladder with CAS. This is discussed in MDT, you are discussing it. So how will you discuss it further?
Okay, so this, from the information I have, this patient has a high risk bladder cancer. The MDT will likely recommend a resection, TURBT, at 4 to 6 weeks to confirm that there isn't any upgrading or upstaging of this tumor. So that will be the initial recommendation of the MDT.
Okay. Why repeat TURBT? What is the evidence behind that?
So the evidence shows that following a repeat TURBT, especially for high-grade bladder cancer, there is incomplete resection in up to 40% of the cases. And for PT1 bladder cancer, there is a potential of upgrading to muscle invasive in up to 20% of the cases.
Okay. And what is other plans if the histology comes negative in the re-resection?
So if the histology comes back negative or confirms superficial bladder cancer, then the management options for this patient, especially for a G3pT1 plus CIS, include intravesical BCG therapy in line with LAM's regimen. But also, because this is a high-risk cancer with risk of progression, there is also an option for an upfront cystectomy in this patient.
Okay, can you explain the LAM's regimen?
So LAM's regimen involves an induction course of BCG 6, and then a 6-week break, and further course of 3. And each course is 1 course a week. And then intervals of 6 months with 3 courses up to 3 years, giving a total of 27 installations of BCG.
Okay. What is your view on a patient's tolerability of the BCG? How much of patients can complete the full course? And if the patient is not able to tolerate BCG, what is your advice?
So the BCG intolerance is one of the potential downsides of BCG. If a patient cannot tolerate BCG, then a consideration of whether they've had an effective dose, which would be 5 out of 6 of the induction or 3 out of 2 of the initial maintenance. So this will be considered. If, however, they completely cannot tolerate BCG, there are all other potential treatment options, such as hyperthermic mitomycin or electromotive mitomycin, but this needs to be done at specialist centers.
How does electromotive mitomycin works?
So electromotive mitomycin works on the principles of using polarized electrical potential to increase the penetration of mitomycin into the urothelial cells.
What about hyperthermic mitomycin?
So hyperthermic mitomycin involves instilling mitomycin at a higher temperature, I think 40 degrees Celsius or 50 degrees, I'm not exactly sure. But this is thought to also improve the penetration and the efficacy of intravesical mitomycin.
Okay. Do you aware of various types of BCG failure, like BCG resistance and BCG relapse? Do you aware of them?
So BCG resistance is defined as persistence of bladder cancer following the initial induction of BCG. The histology of the persistent tumor does not progress, but could be of the same grade or less. BCG refractory means that the patient has BCG, and despite this, there is evidence of progression, histological progression of the tumor. Whereas BCG relapse means recurrence after completing a course of BCG.
Okay, so what is BCG?
So BCG stands for Bacillus calmette guerin, and this is a live attenuated Mycobacterium bovis. It works on the principles that when BCG is instilled into the bladder, it's incorporated into the urothelium by the fibronectin receptor, bringing about immunological response and reaction in the bladder that leads to destruction of cancer cells. The evidence is that this prevents recurrence, but more importantly, prevents or has benefits in terms of preventing progression of bladder cancer.
Okay. After the BCG installation, this patient developed significant dysuria and frequency. How can you help him?
So the such side effects from BCG, if a patient develops that, it's important to exclude a urinary tract infection. So I'll send off urine for culture, and if there's any evidence of UTI, to treat that episode. I'll advise the patient to increase their fluid intake to keep the urine dilute and empty their bladder regularly. These conservative measures may actually be what the patient requires to manage the symptoms.
Okay, and by chance, if the patient has no improvement and there is no signs of any infection in the urine, any other measures?
I'm not exactly sure of any other measures apart from the conservative ones.
Okay. The patient which you have treated successfully had the induction course of BCG and the maintenance for 1 year. After 1 year, there is a recurrence of lesion in the floor of the bladder. The resection showed G2 high-grade PTA. How are you going to proceed?
So I will rediscuss this at the urology MDT. And given that this is a lower grade compared to what it was before, MDT will likely recommend to carry on and complete the course of maintenance BCG.
Okay, we will stop there. How do you think you did?
So I think I progressed well. I hope I got through to the end of the station.
Yeah.
The BCG, and it's a very topical issue with urology. The definitions, sometimes I do confuse them, but I hope I got them right in terms of relapse, refractory, and BCG failure.
Yeah.
But overall, I think I answered the questions appropriately.
Yeah, correct. I think for this high-risk non-muscle invasive bladder cancer, you did much better. No major concerns. The best place to refer the BCG types of failure is the EAU guidelines. It's very nicely described.
Yeah.
And LAM regimen, Sylvester trial, everything is very nicely done. And for the BCG cystitis symptoms, you can start anticholinergics or mirapegrone. Nothing wrong in that. Lifestyle changes. If the patient is still smoking by chance, avoiding smoking, decaffeinated drinks, appropriate hydration, avoiding constipation, all the normal things. And then nothing wrong in starting with, say, sulfasenacin. And if the patient is not able to tolerate, or if there is no improvement, maybe mirapegrone. And when you're doing a flexible cystoscopy, you can try to access the volume of the bladder, even though we tend not to overfill the bladder, especially in flexible cystoscopy. If the
Yeah.
patient attends for any GA cystoscopy like TRBT or GA cystoscopy biopsy, that's a good time to assess the bladder volume and document it. So if the
Okay.
patient develops BCG cystitis, we can correlate, is it just due to the irritation or the BCG changes in the mucosa, or is it due to the low volume in the bladder or loss of bladder
Okay.
capacity?